Good morning and welcome, good morning, good afternoon. My name is Jocelyn McCardle, and I am your moderator for this session. I am a almost 7-year breast cancer survivor, so I wanted to welcome everybody today to the YSC Digital Summit. Just some housekeeping. We are taking questions in the chat, so I will be monitoring those throughout. This is being audio and video recorded, and they will be available for the next 30 days as long as you are registered for the conference. And then at the end, I'll talk about the evaluations and what's going on for the rest of the weekend. So without any further ado, I would like to introduce our speaker, Irene Su. Irene, take it away.
Good morning. I'm Irene Su. I am a reproductive endocrinologist and epidemiologist at the University of California, San Diego. I wanted to thank you for joining today. Jocelyn and I had talked about wanting a more informal session, and I know some folks are also on phone only, and so I'll be reading through hopefully not very many words on the slides. So as interactive and as helpful as we can be, I'm looking forward to talking about this topic, pregnancy after breast cancer. Let me share my slides and then we will go from there. Okay, so the usual question, you can see my slides, yes? Okay. So I thought we would frame this as questions and answers. And there are 6 questions that in clinical care I often encounter with my patients. One of the first questions is it safe to become pregnant? And I wanted to talk a little bit about the impact of having a history of breast cancer on maternal health, and then in the next slide on offspring health. And so on maternal health, it's clear that in young breast cancer survivors who choose to become pregnant, that overall there is not a higher risk of breast cancer recurrence or death compared to breast cancer survivors who did not become pregnant. And these are really observational studies. It is that ahead of pregnancy, if certain medications that someone is exposed to at high doses, specifically a medicine called doxorubicin of over 250 milligrams per meter squared, that requires having a heart evaluation through an ultrasound called an echo. We talk about trying to screen for breast cancer recurrence ahead of pregnancy. And ultimately, it's a really personalized decision between a patient, her oncologist, and any reproductive specialist, people like me, to help make that decision on how and when to try. But currently, there are no national or international guidelines on when it is the safest to become pregnant. On the right is a part of a reproductive risk summary that my team and I have worked on for a while now, and we summarize it for this particular patient as the risk of during pregnancy are low because of the treatments that they have. So they had received a medicine called cyclophosphamide at 2.4 grams per meter squared. That's a pretty typical dose. That because of the age of that patient posed a low risk, and that's why a green box there. Endocrine therapy, hormone therapy like tamoxifen, or being on ovarian suppression with an aromatase inhibitor or tamoxifen, those are not directly toxic to the ovaries. However, being on it for prolonged periods of time, 2 years, 5 years, 10 years, we are aging concomitantly. We think that other types of chemotherapy related to breast cancer treatment often are not super toxic to that finite number of eggs that we have. And then chest radiation also potentially requires a screening of heart prior to pregnancy. And overall, the research supports no increased risk of breast cancer recurrence or death. However, because tamoxifen during pregnancy can cause birth defects, this is why you have to be off of tamoxifen for about 2 to 3 months before you conceive. And with chest radiation or high doses of doxorubicin, there are very, very small increases in pregnancy cardiomyopathy and thus the echo screening. The second question is really on how healthy are my kiddos going to be. And as I said in the prior slide, the current recommendations are to stop tamoxifen 2 to 3 months before the pregnancy attempt. And then things like lifestyle, so managing weight, having a higher physical activity level, avoiding smoking, no alcohol or marijuana use during pregnancy. Those are all preconception lifestyle changes that we can modify to have the healthiest pregnancy. And on
Irene,
please.
we have our first question. I don't know if
Great.
you want to address it quickly.
Yeah.
How long should you wait after Lupron?
Yeah, actually, after Lupron, if you have, so people are on Lupron with aromatase inhibitors or Lupron with tamoxifen. And so the Lupron itself, you don't have to wait. It is that after, and sorry, for the whole audience, Lupron is a GnRH agonist, and it is used as a hormone therapy to reduce the amount of estrogen that a woman sees. And it works by telling your brain, don't signal to your ovaries. And so the primary limitation of Lupron is because that's the way it works, that you may not ovulate straight away. But once you ovulate, that's great. That's it. That's the effect of Lupron. So you do not have to wait. You simply have to sort of let your body recover and start to grow an egg again. And then if you're on Lupron plus tamoxifen, then the same guidelines for tamoxifen. There is not the guidelines for aromatase inhibitors because it's out of your system pretty fast.
All right. And then someone had quickly asked, is it the same suggested wait time, 2 to 3 months, if you're on letrozole or tamoxifen or any type of AI?
Right. So tamoxifen is a SERM and not an AI. So the tamoxifen guidance is here 2 to 3 months. But for AIs, no, you should be able to stop and then attempt pregnancy. And in fact, aromatase inhibitors were originally a fertility drug. So it is used in ovulation induction for fertility management. And there's no, it's in the whole process of trying to get pregnant.
Okay, great.
On the right, I'm showing you the population-based sort of research studies that show here the risk of having a preterm baby, so delivering before 37 weeks, is about 1 in 10 American pregnancies. And then in breast cancer patients, it's like 1.5 out of 10, so mildly elevated. And because there's a slightly higher risk of delivering early, therefore you have similarly a slightly higher risk of having a lower birth weight baby because lower birth weight, so preterm delivery results in a lower birth weight baby.
All right, there's another question from Lauren, particularly with ER positive and PR positive breast cancer. Are there additional risks associated with IVF?
That's a great question. So the short answer is that data are limited but suggest no, but there are ways that you can mitigate an IVF cycle to try to reduce the amount of estrogen. So we often use letrozole in conjunction with stimulating the ovaries so that you can use really brain hormones, FSH, LH, to push the ovaries to grow multiple eggs, but then add letrozole, that aromatase inhibitor, to reduce the amount of estrogen that each egg makes. And so 3-5 year data from fertility preservation cycles in breast cancer patients show no higher risk of recurrence, but this is not thousands of women for 20-30 years kind of data.
Thank you.
The next question is, well, how do I know if I'm fertile? And that's a question whether someone is a young breast cancer survivor or whether that person is of reproductive age. And so the simple answer is you don't know unless you try to become pregnant. So that's why here I listed, you know if you're fertile if you try to become pregnant and then you become pregnant. I want to talk briefly about ovarian reserve markers and menstrual pattern because those are often clinically other assessments. And so ovarian reserve markers are direct or indirect measures of how many eggs are remaining in the ovary. And you'll hear that as ultrasounds for something called an antral follicle count or blood tests for AMH and FSH. So these largely tell us if you were to go through fertility treatment, how likely are we to get a good number of eggs? But these markers do not and have not been shown to say A low AMH, which is a sign of low ovarian reserve, it's not related to how long it takes someone to become pregnant. And same thing that sometimes, especially post chemotherapy, women will experience more irregular bleeding because you haven't started to ovulate in a regular way. But once someone ovulates, then there is the potential for pregnancy. So, this is a long way of saying that ovarian reserve markers and menstrual patterns are helpful for us to understand kind of what is the pool of eggs and are you ovulating, but it does not do as good of a job at predicting fertility. Moreover, these markers change over time because acutely post ovarian suppression or acutely post chemotherapy, that signaling from the brain to the ovary to make an egg every month is sometimes a little bit messed up, but will recover over time. And that's why clinically, even though we assess these in our patients frequently, it's not a one-time assessment because markers can change over time.
We have a few questions in the chat. Jamie's newly diagnosed. They give her shots that put her into menopause, and she's wondering, how long are you on this type of medicine? Does it ever end? First question. Jessica is asking, what birth control can I use being triple positive?
Those are great questions. So the first question is brought up earlier, the question of being on Lupron or goserelin. These are all a part of a class of medicines called a GnRH agonist for ovarian suppression. They have two uses in breast cancer survivors. The first use is to preserve fertility during chemotherapy. And so, to this person's question, we would expect GnRH agonists to use during the time that you are on chemotherapy, but not during the time that you are on hormone therapy. But the second use of ovarian suppression is not for fertility preservation, but for breast cancer prevention of recurrence in people who are ER/PR positive. And that's a decision made with your oncologist. So those folks who are on this for hormone therapy can be on it. The recommendation is 5 to 10 years, and it's a personalized decision with your physician as to whether you take a break at year 1, 2, 5, 10 in order to try to become pregnant. The second question is contraception, and that's a pretty easy one. And I have a slide at the end, but the short answer is to use a copper IUD, which has no hormones, highly reversible. And that is what is recommended by the World Health Organization in national guidelines.
Thank you.
I think I spoke to this a little bit already. The next question is, well, what affects fertility? So we know that alkylating chemotherapy, and specifically that is a drug called cyclophosphamide, decreases the finite number of eggs that we have. The other thing that affects fertility is our age, because we have a finite number of eggs. What tends to improve fertility is ovarian suppression during alkylating chemotherapy, which we talked about in this prior slide. And so there are some small randomized controlled trials that show that in breast cancer patients who are on, who get alkylating chemotherapy, that being on ovarian suppression increases their chance of having periods, meaning that the ovaries are ovulating, and increases their chance of fertility or having a pregnancy and having a delivery. But that effect is really small. What also improves fertility is fertility preservation before cancer treatment. On the right, I said neither hormone therapy, the caveat. So endocrine therapy, tamoxifen, Lupron, ovarian suppression after acute treatment. So those are like the 1, 2, 5, 10-year endocrine therapy. Those things do not directly hurt your eggs. But what's happening is that you're just aging in the meantime, right? Because your fertility at 25 is not the same as 35. At 35, 10 years later, is not the same as at 45. What remains unknown are combinations of chemotherapy and also all of these new great targeted therapy drugs. There's very little known about them. But we're working on that on the research side.
There's one question from Carolina. Is there any contradiction or waiting time after getting last Zometa? She's 37 years old. She was diagnosed at 34 with ER/PR positive on Lupron and an aromatase inhibitor. frozen embryos and I would like to attempt pregnancy. The doctor told me that I need to be asking what are my chances of cancer reoccurrence versus the chances of those two embryos actually working. I would appreciate your input. I'm also curious about the process to try implantation. Do I need to wait and see if I get a period? Thanks.
Yeah, so thank you very much for that question. And I think that the summit leadership had asked us probably not to directly address a specific sort of patient scenario. So I'll keep this broad. So I think that the two questions that you've raised are what is the impact of Zometa, which is a bisphosphonate? It is to try to prevent recurrence on pregnancy. And then the second question really is, well, how do you do a frozen embryo transfer of some of embryos that you have frozen before? So it's an interesting question. There's not a lot of data on Zometa. So bisphosphonates remain in our bones for a very, very long time. You cannot use bisphosphonates during pregnancy. And the idea is that it's possible over time that the drugs like bisphosphonates that are incorporated in our bones will slowly seep out. So this means that, for example, pediatric endocrinologists who use this drug for people with bone problems, kids with bone problems, talk a lot about not using them in women of reproductive age. But we know the reality is that Zometa decreases the risk of breast cancer recurrence, so you're going to use it. So there is a theoretical risk. And so what we've been doing with our patients who are on Zometa is to say 3 to 6 months off drug prior to pregnancy, with a caveat that we know very little about the impact on pregnancy, on the development of the kiddo. I think it's a theoretical risk. The second question is, how do you do a frozen embryo transfer? So if someone has ovarian function, meaning they get their periods back after being on the GnRH agonist, then you can try to have a natural cycle frozen embryo transfer. So that means that a woman ovulates on her own, and we put the embryo back 6 days, 3 or 6 days later, depending on the stage of the embryo that was frozen, as opposed to a program cycle. And in a program cycle, we replace estrogen and we replace progesterone as injections or as vaginal suppositories. In the right patient, they have equal rates of success. And so those are options that you discuss with the reproductive endocrinologist. And to the last question, should you put those embryos back? I think that becomes a decision with a breast oncologist to say, if I take a break in endocrine therapy, how much is this going to try to become pregnant? How much would this impact my chance of recurrence, right? There's a risk with every choice that we make. It's just sort of the magnitude of the risk that informs what you do, if that makes sense at all. And so I think I'll stop there because, yeah. Is that all right, Jocelyn? Did I answer your
Yes,
question?
there's another question, but I just want to be mindful of the time. We have about 12 minutes left. So I want to make sure you get through your slides. I don't know if you want to take one more question and then we can continue on.
Yeah, let's do it.
Is there anything that can be done to ensure that eggs are matured enough for preservation if retrying IVF? All 15 of mine were immature when I tried prior to chemo. Thank you.
Yeah. Yes. So the question is, for the audience, when someone tries to stimulate the ovaries, ultimately you need a mature egg to become one of us, to become human. And so in rare circumstances, all eggs can be immature at the time of retrieval. And so it's known that in IVF stimulation, if you try to use letrozole to try to reduce the estrogen exposure to that patient, you really need that the size of the follicles are larger. And so for our patients, when rarely, you don't get as many mature eggs as you want, I think largely they improve on the next cycle. But there are things like considering the size of the follicles, the type of medicine you use to trigger ovulation, the final step in maturing those eggs, and then the amount of time between that trigger and the retrieval. Those are very commonly manipulated parts of IVF that you use to try to reduce the chance that this happens again. And largely patients do better the second time.
Great.
Okay,
Thank
I'm gonna
you.
keep going.
Yes.
Next question, can I breastfeed? So for women who who have the capacity to have breast and breastfeed, the risks during breastfeeding are low. This is a part of our survivorship care plan that I was showing you earlier. So it's known that breasts that have been treated with radiation or surgery, they'll produce less milk, but a baby's breastfeeding need or feeding needs can be met with one working breast. We know that tamoxifen can suppress lactation. The exception is that it's not safe to breastfeed while on chemotherapy. The information on aromatase inhibitors like letrozole, exemestane, trastuzumab, actually there's very little data in the manufacturing specifications on those drugs are no. While breastfeeding, it's okay to do mammograms. There are no adverse events from breastfeeding after contrast-enhanced MRI, but often women will discard milk for 12 to 24 hours after getting contrast. And you can either breastfeed or express the milk before you do the MRI or mammogram imaging, just to decrease the density of the breast so that the radiologist can see better. Okay, this was the slide I wanted to show earlier. What if I want to prevent pregnancy? What are the hormone-free birth control methods that are available for breast cancer survivors? And how reliable is it? There's a really nice website called bedsider.org. It is not targeting cancer survivors, but has good, reliable information on contraception. And we've highlighted here that a copper IUD is the most recommended. It's reliable because less than 1 out of 100 women with a copper IUD in will have an unintended, unplanned pregnancy. It lasts up to 10 years, but the moment that you take it out, your fertility is what it is. The side effect that's common to a copper IUD is having heavier periods and cramps. So when that happens to our patients, we talk about sort of the risk benefits, and they either continue to experience heavier periods, cramps that you can't resolve without taking the copper IUD out, or decide that that's not the right method for them. But by and large, breast cancer survivors, at least in our practice, have adhered to and like this option rather than worrying about an unplanned pregnancy. Sterilization with tubal ligation or partner vasectomy, again, is just as safe as a copper IUD. But this lasts a lifetime, and it's really difficult to reverse it. Cervical caps, diaphragms, condoms, withdrawal, or rhythm method, all, to me as a physician, as an obstetrician gynecologist, really have unacceptably high rates of having an unintended pregnancy. So for example, for cervical caps and diaphragm, if you take 100 women who are using that for a year, 16 out of those 100 will have an unintended pregnancy. And rhythm method simply means that you are not having sex at the time that you think you may be ovulating. That's basically a quarter of women who have an unintended pregnancy. And I think we can be more intentional and safer about contraception. And actually, I got through all of my slides. I think Jocelyn would be proud of me, and we still have 5 minutes to talk.
Awesome. Well, we have another question from Lindsay. She says, I know fertility decreases with age. What age does it become too risky or not possible?
That is so variable. And so I think that's a really difficult question to ask. Maybe one way to address it is to think about what it is in the general population, because depending on your current age and on what type of breast cancer treatment that a person is undergoing, that there's just a lack of data to help answer that question. So in the general population, when we were 25, that's when we were the most fertile, 25% per month if you were having unprotected sexual intercourse with a male partner. When you're 30 to 35, still about the same, 25%. Toward the mid to late 30s, probably more like 15-20%. For 40-year-olds, the data are pretty good, 10 to 15% per month. And then at 42, it's like less than 5% per month. So that's what it is in the general population. I think experientially, the younger a breast cancer survivor is, um, even if you have low ovarian reserve, those eggs are good. The quality of the eggs is best described by a young age, and so that's why you can have a young breast cancer survivor with very few follicles, low AMH, high FSH, but they still have very much the possibility of conceiving using autologous eggs because the quality of the eggs are good.
We have a couple more questions. Callie said she tried IVF after treatment and was unable to produce any eggs, was told that there was nothing else to try because of the cocktail of drugs I used were the only safe option. Are there new safe options I can explore?
So I think that the question is, are there different IVF medications to use to try to make embryos? So no, the staple of IVF remains using FSH and LH, which are the hormones from our brain, just higher doses of them, but to try to get multiple eggs to grow. And so what cannot be changed is what someone's ovarian reserve is. So if there is a finite number of eggs, 2 to 3 possible eggs in a given month, then really it's kind of luck of the draw whether those are 2 to 3 eggs will give us a baby. And so that I think is only a little bit changeable in that ovarian reserve can change over time. So someone who tries to stimulate immediately post chemotherapy within 3 to 6 months, it's possible that your ovaries will recover. So it may be, depending on that person's age, it may be worth following up to see if ovarian reserve got better over time. And then the other part of it is that the art of IVF, so the drugs are what they are, but how we approach it, high dose, low dose, this protocol, that protocol, how good your IVF lab is, those are things that are also a little bit modifiable to try to improve outcomes.
All right, we have time for one more question, but I just want to remind people your contact information is up on the screen. So those questions that we haven't gotten to, feel free to email Irene with your questions. And then just a couple housekeeping items. The summit will be sending you a survey about how our session went today, and you will be entered into a drawing for a $50 YSC merchandise credit. We will post the link, the YSC website link, so you can hop on there and check out other breakout rooms. Last question, Irene. If I use an egg donor, my fertility failed and I have not great eggs, it seems, can I carry that baby still? That's from Jamie.
Yeah, that's a great question. And yeah, so we don't think that any of breast cancer treatment impacts a woman's ability to carry a pregnancy in her uterus. I showed you a little earlier that ever so slightly higher risk of preterm birth that we don't super understand yet, but there are things you can do to make sure your body's ready. For example, making sure your heart is healthy, making sure all of the lifestyle choices that you can make going into a pregnancy is as optimized. And so it's known that even if someone is menopausal, meaning no more eggs remaining, it is absolutely possible to have a healthy and high chance of having a baby using donated eggs, donated embryos. And of course, deciding that your family size is good as it is, or adoption, or living child free, those are all in the gamut of what's reasonable and what people choose.
Awesome. Thank you so much, Irene. I just want to also inform attendees that YSC is hosting a virtual half-day metastatic retreat on June 4th. So you can visit the YSC website, which I know our friends have put in the chat. It was such a great honor to have you speak today. Thank you so much for addressing a topic that is also near and dear to my heart, as I am on a fertility journey as well. Thank you guys so much for attending. I hope you have a great summit. Enjoy the rest of the weekend.
Yeah, thanks everyone. Thanks, Jocelyn.